Good afternoon, everyone, and welcome to a new session for San Antonio, Clinical Controversies. Today you're going to hear a series of controversies that are sort of debated, sort of explained by two experts in each field. We'll have a polling session, which hopefully will go well. Then we will have the presentations, and then we will have a redo poll to see how people have learned. And I promise you that the questions are hard ones, so don't feel too daunted. All right, if you could put up the slides. I'm Lisa Carey. I'm from the University of North Carolina, and I have the pleasure of moderating this. And I want everybody, we're going to do all three poll questions, and then we will start with the first controversy. So poll question number 1, sentinel lymphadenectomy in patients with clinically involved nodes treated with neoadjuvant chemotherapy who convert to clinically node negative has been shown effective with low false negative rates as long as dual tracer is used and at least 3 sentinel nodes are removed. Residual nodal involvement warrants completion axillary dissection. So local management of T2N1 disease that converts to node negative with neoadjuvant chemotherapy plus anti-HER2 therapy includes all of the following. Which of the following? A, sentinel lymph node dissection followed by axillary radiation and residual ITC. B, sentinel lymph node dissection followed by axillary dissection and residual nodal ITC. C, regional nodal basin and axillary radiation if clinical and radiographic CR. And D, regional nodal basin radiation alone in clinical and radiographic CR. Here's hoping the polling goes well. I'm being told to not touch anything up here while the countdown is happening. Okay, polling seems to be working better than earlier. Wonderful. All right, we'll go to question number 2. I can click now, right? Okay, poll question number 2. Patients with hormone receptor positive breast cancer continue to be at risk of late recurrence. For example, meaning more than 5 years from diagnosis. Multiple trials have demonstrated improved outcome with extended adjuvant ET after the first 5 years with either AI in postmenopause or extended tamoxifen regardless of menopause. However, cumulative toxicity becomes more prominent. Genomic assays can identify risk of late relapse and benefit of intervention, although the value added over clinical modeling is not yet clear. Appropriate endocrine management of late relapse risk in an otherwise healthy woman includes all of the following except A, AI for 10 years in a 55-year-old postmenopausal woman with T2N1 grade 3 IDC. B, AI in ovarian function suppression for 5 years, then tamoxifen for 5 years in a 40-year-old premenopausal woman with T2N2 grade 2 IDC. C, tamoxifen for 5 years, then raloxifene for 5 years in a 55-year-old postmenopausal woman with T2N2 grade 2 IDC. Or D, tamoxifen for 5 years, then no further endocrine therapy in a 40-year-old premenopausal woman with T1N0 grade 1 IDC. Fantastic. All right. And our last question is the Keynote 522 trial in early triple-negative breast cancer demonstrated improved pathologic complete response rate and EFS with adding immune checkpoint inhibitor to neoadjuvant polychemotherapy and continued into the adjuvant phase. A similar EFS benefit of ICI alone during the ICI given only during the neoadjuvant phase was seen in the Gepar-Nuevo trial. Prior adjuvant therapy in the residual disease setting included capecitabine or olaparib in germline BRCA carriers. For triple-negative disease with residual disease after neoadjuvant chemotherapy plus ICI, reasonable options include all of the following except A, pembrolizumab alone, B, pembrolizumab plus olaparib, C, pembrolizumab plus capecitabine, D, capecitabine plus olaparib, or E, capecitabine alone. Thank you. All right. So I'm going to now turn to the clinical controversy number 1, to clip or not to clip. Our experts to speak today are Dr. Viviana Galimberti, Professor and Director of Sinology at the European Institute of Oncology in Italy, member of the Board of Scientific Direction of the EIO, with training in plastics as well as oncologic surgery. She also has an advanced degree in healthcare management. Our second speaker is Abigail Caudle, a professor in the Department of Breast Surgical Oncology at the University of Texas MD Anderson. She serves as the Vice President for Procedural and Therapeutic Medical Operations. Her research focuses on novel surgical techniques and methods for assessing response to therapy. Dr. Galimberti.
Thank you, Lisa, for inviting me here in this late controversy, clip or not to clip. And I present quickly our clinical case is a premenopausal woman with a tumor of T2 and 1 M0, no medical history. She underwent core biopsy that revealed an infiltrating ductal carcinoma, triple negative, G3, and Ki67 9%, with a positive node in the axilla revealed by fine needle biopsy. After neoadjuvant chemotherapy, there reaches a clinical complete response, also by imaging, MRI, mammography, and ultrasound. And so the question, after a genetic panel test that revealed no mutation, we do a conservative surgery, but the question is clip or not to clip, TAD or clip. And this, I want to try to convince you that sentinel alone may be a safe and viable way. However, what we have in common in this controversy is that we want to de-escalate axillary surgery to improve quality of life for this patient as well. International guidelines said that sentinel node is permitted instead of axillary section in these cases, provided we remove more than 3 negative nodes or marking this with clip. In fact, in this meta-analysis, you can see that if you remove 1, 2, or more than 3 nodes, you can see that false negative rate changes. And if we remove more than 3, the false negative rate reaches 4%. All these efforts to find the localization technique and research to try to find possible full response predictivity start from the false negative rate concept. But why is this so important? We have learned from several studies in upfront surgery, and maybe the most significant is Z11 that found also 27% of other axillary positive node in the axillary dissection arm, but this did not translate in bad outcome and not higher axillary recurrence. In favor of sentinel node alone, we have 5 studies with different follow-up and with low axillary recurrence, less than 2%. Let us consider the last study, the study by Piltin from the Mayo Clinic. They had a median follow-up of 34 months, and they removed a median of 3 nodes. And here you can see they had only 1 axillary recurrence, 0.7%, and so they decided after this study to introduce this in clinical practice. The second study by Wong, again with sentinel node alone. Here you can see the study design. They found 58 cases out of 102 that converted to negative. And in these cases, they found no axillary recurrence. And in 71% received regional nodal irradiation. the study from the Sloan Kettering, again with sentinel node alone, with dual tracer, and the removal for more than 3 negative nodes, and the outcome was axillary recurrence. And here you can see the design study. They got an incredible high conversion rate, 91%, and in 42% they did not perform axillary section because the sentinel nodes were negative. And they had only 1 axillary recurrence in a patient that refused radiotherapy, while all the others that received radiotherapy developed no axillary recurrence. And this is the study from the National Cancer Institute in Milan, with a median follow-up of 87 months with sentinel node alone and using only radiotracer, and had the removal of a median of 2 sentinel nodes removed, and in 33% only 1 sentinel node. And here you can see the study design, 81 out of 121 that converted to negative, no axillary recurrence as well. And the 10 years overall survival between those that received sentinel node versus sentinel node and axillary dissection revealed no statistical difference. And this is our first study with 396 patients that started negative and positive. And in the group that started with positive axilla prior neoadjuvant chemotherapy, we found only 1 axillary recurrence. And the 5 years distant disease-free survival and overall survival between those that started with negative or positive found no statistical difference. So after these encouraging results, we continue our policy only with radiotracer and regardless the false negative rate. And here you can see the study design. We recruited 222 patients that converted to negative, and those received sentinel node biopsy. Our endpoints, in addition to axillary recurrence, are overall survival and distant disease-free survival. Here you can see that in the group that started with a negative axilla developed with the sentinel node negative 7 axillary recurrence, 1.5%, while those with isolated tumor cell and micrometastasis that did not perform axillary dissection, no axillary recurrence, while those that started with a positive axilla and converted to negative with a negative sentinel node, 2 axillary recurrence, 1.6%, and 2 axillary recurrence in those with micrometastasis in the sentinel node that did not axillary dissection. And overall survival and distant disease survival, according to the CN status prior neoadjuvant chemotherapy, reveal no statistical difference. So our conclusion is that the 10 years of follow-up confirm our preliminary results that the use of a standard technique with radiotracer alone, no clip, is acceptable because did not translate in a bad outcome, particularly in those that had a good PCR. There are some trials that are going to answer some questions that are not resolved. For example, what to do with the positive sentinel node after NACT, if we can de-escalate radiotherapy with PCR in the axilla, and finally, if we should even avoid sentinel node biopsy in triple negative, but this starting with a negative axilla. So I may conclude saying that CLIP surely reaches a false negative rate of less than 10%, and Abigail will explain you better, but in my opinion is more expensive, more time consuming, more difficult to identify, unknown how many nodes should be clipped, unknown what to do in case of lost clip, and particularly we have no data on the outcome. While by my side, not clip, if we remove more than 2 negative nodes, we can reach the same false negative rate, less than 10%. We know that if we remove less than 2, we can reach a false negative rate that can be higher than 10%, but is less expensive, easy to identify, and even if we remove less than 2, we have low axillary recurrence and good outcome. Thank you very much, and I hope to try to convince you that sentinel node is better.